About 5 to 10% of our colic cases are actually surgical, and missing one of these or delaying their referral can severely impact their survival rate. This is, of course, the one that we always worry about, that we go out to a colic and that we might miss a lesion. So let's review some of our surgical colic cases. The intestine might become incarcerated or trapped somewhere. It might twist or it might get strangulated. Essentially, anything that's going to require a manual correction is considered a surgical lesion. The small intestine can do all of these things, even telescoping into itself during an intussusception or getting impacted by roundworms. Any way that it occurs, an intestinal strangulation is by far the most painful form of colic. And this is because the intestine don't have pain receptors, but they do have stretch receptors, which means that as that small intestine dilates beyond a certain point, which doesn't take too long, that pain response is elicited. Another area that has a lot of pain receptors is the mesentery, which means that when the mesentery is involved in a torsion, you also see an acute and violent pain response. An important feature when dealing with small intestinal strangulation is that the colic might start out very violent, but then subside as it goes on. The reason for this is that the horse might initially have small intestinal dilation or mesenteric pain reaction, and then the horse develops endotoxemia and shock, and the pain subsides when the small intestine devitalizes. For this reason, surgical treatment of those strangulations are critical within a certain time window to decompress and resect the affected intestine before it spreads, and recognizing that post-operative ileus, which is unfortunately common, but the severity of which is going to depend on the region and the extensiveness of that small intestinal lesion.